Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, JAIPUR. In today's lecture, we are going to continue with the glomerulonephritis. This is the third lecture of the series of glomerulonephritis. In the first lecture, we have discussed about the nephrotic syndrome. In the second lecture, we have discussed about the nephritic syndrome. And today we are going to continue with this series, the different type of other glomerulosclerosis and other changes in the nephropathy in the kidneys that we are going to see. So let's start our today's lecture. So in the last lecture, let me have a quick review of the different type of glomerulonephropathies that we have discussed. We have discussed about the nephritic syndrome, that it is characterized by azotemia, hypertension, edema, hematuria, proteinuria, and sometimes oliguria. RBCs were prominent in nephritic syndrome. Then we have discussed about the minimal change nephropathy. Minimal change nephropathy that is characterized by normal blood pressure, normal GFR or slightly reduced GFR, the urinary sediments that is benign or with few RBCs, and it does not progress to CKD. Then we have discussed about the primary focal segmental glomerulosclerosis. It is of two types, primary type and the secondary type. And these progress to the CKD, chronic kidney disease. And it is present with variable amount of proteinuria. And this does not get relieved by glucocorticoids or the corticosteroids. The third variety that we discussed in the last lecture was membranous nephropathy. Membranous nephropathy, it is the most common type of nephrotic syndrome in the adults. And the patient were present with edema and the nephrotic proteinuria. 1/3 of the patient were remitting with the membranous nephropathy, remitting spontaneously. 1/3 had nephrotic syndrome, and 1/3 showed progressive loss of the renal function. The treatment was with high dose of corticosteroids and the alkylating agent that improved both nephrotic and the long-term prognosis. Now let's start with today's lecture with the glomerulonephritis part 3. So I must recall you that about the picture in the book that we have discussed about, in which the glomerulonephritis is shown with different varieties. On one end, we have nephrotic syndrome, and the other we have nephritic syndrome. Nephrotic syndrome is characterized by proteinuria, whereas nephritic syndrome is characterized by hematuria. So there are different type of changes, which includes minimal change nephropathy, FSGS, membranous nephropathy that we had discussed in the last lecture. Now we are going to start with the other different type of nephropathies. So today we will start with IgA nephropathy and Henoch-Schönlein purpura. So what is IgA nephropathy? IgA nephropathy is the most commonly recognized type of glomerulonephritis. So if we are talking about the most common type of or most recognized type of glomerulonephritis, then IgA nephropathy is one of the type. And it can present to us in many ways. There is hematuria. Hematuria is the earliest sign of, and it is the most universal in many ways. So we have hematuria, that is the earliest sign, and it is almost universal. So in IgA nephropathy, we will have hematuria, we will have proteinuria, and we will have hypertension. Three things we need to remember. Hematuria, that is blood in urine; proteinuria, that is protein in the urine, that is albumin in the urine; and hypertension, that is raised blood pressure. So we will have hematuria, we will have proteinuria, and we will have hypertension. In some cases, there is severe proteinuria. So in some case, you will have severe proteinuria. We have hematuria, we have proteinuria, and we have hypertension. So in some of the cases, there is severe proteinuria or the loss of renal function that can occur. It is a common cause of end-stage renal disease. So IgA nephropathy, it is the most commonly recognized type of glomerulonephritis, and it can present in many ways. Hematuria is an earliest sign, and it is almost universal. The proteinuria, it is the later feature, and hypertension is very common. So we have hematuria, that is very common. Proteinuria is a late feature, and hypertension that is also present. In some cases of the severe proteinuria or the loss of renal function, it can occur. It is most common cause of end-stage renal disease, that is IgA nephropathy. The exacerbations in young adults are acute and self-limiting. So if it is occurring in the young adults, then it is self-limiting, and it is often with gross hematuria and is associated with minor respiratory infections. So the exacerbation, if you see the exacerbation in the young adults, it is basically self-limiting, and it is often with the gross hematuria and in association with minor respiratory infections. The exacerbations are so acute as to resemble acute post-infectious glomerulonephritis. So the exacerbations are very much acute, and they resemble acute post-infectious glomerulonephritis with fluid retention, with hypertension and oliguria. So there is retention of the fluid, there is hypertension, and also there is oliguria. So exacerbations of IgA nephropathy includes acute post-infectious glomerulonephritis with fluid retention, hypertension, and oliguria. The duration from the clinical infection to nephritis is very short. So once there is infection, then nephritis develops very fast and within a few days or less. IgA nephropathy progresses rapidly and crescently formation may be seen. So the duration from the clinical infection to nephritis is very short and few days or less are seen. IgA nephropathy progresses rapidly and the crescent formation may be seen. The systemic vasculitis in the children and adult in response to infection, it is known as Hematuria purpura. So in response to infection, if there is systemic vasculitis, that is inflammation of the vessels in children and adults, then it is known as Hematuria purpura. So Hematuria purpura is nothing but the systemic vasculitis that occurs as a result of infection as seen in children and adults. Now it is characterized, the Hematuria purpura, it is characterized by petechial rashes. So you are going to see petechial rashes, that is cutaneous vasculitis, typically affecting the buttocks and the lower legs. So in case of Hematuria purpura, there is a systemic vasculitis and it is characterized by petechial rashes. Petechial rashes are the cutaneous vasculitis that is typically affecting the buttocks and the lower legs. There is also abdominal pain with gastrointestinal vasculitis. There is mild glomerulonephritis indicated by hematuria. So there is petechial rashes, that is cutaneous vasculitis, typically affecting the buttocks and the lower legs. There is abdominal pain, that is gastrointestinal vasculitis. Mild glomerulonephritis, that is indicated by hematuria. There is also renal biopsy that shows mesangial IgA deposition and appearances indistinguishable from the acute IgA nephropathy. And the response to immunosuppressive therapy is poor. So Hematuria purpura, it is characterized by petechial rashes. There is cutaneous vasculitis that is typically affecting the buttocks and the lower legs. There is abdominal pain, that is gastrointestinal vasculitis, with mild glomerulonephritis that is indicated by hematuria. There is also renal biopsy that shows mesangial IgA deposition and appearances indistinguishable from acute IgA nephropathy. The response to immunosuppressive therapy is poor. And the management of the less acute disease is to control the blood pressure. So in the management, you have to control the blood pressure and you have to prevent or retard the progressive renal disease. So for the management of Hematuria purpura, we have to control the blood pressure and we have to prevent or retard the progression of the end-stage renal disease. Next, we come to the another variety, that is glomerulonephritis, that is associated with infection, or mesangiocapillary glomerulonephritis. So glomerulonephritis that is associated with infection or mesangiocapillary glomerulonephritis, it is basically subacute bacterial infection. So it results from the subacute bacterial infections, that is bacterial endocarditis, and it causes a variety of histological pattern of glomerulonephritis. It is most typical with the membranous and mesangiocapillary lesions, that is MCGM, and with plentiful immunoglobulin deposition. The glomerulonephritis, it is more common, occurs following the hepatitis B and C infection, schistosomiasis, leishmaniasis, malaria, and the other chronic infections. And providing a causative relationship between the renal disease and the infection in individual cases, it is difficult. So in glomerulonephritis that is associated with infection and mesangiocapillary glomerulonephritis, there is subacute bacterial infections, that is bacterial endocarditis, and it causes a variety of histological pattern of glomerulonephritis, most typically with the membranous or mesenteric-capillary lesions, with plentiful immunoglobulin deposition. There is also glomerulonephritis, more commonly occurring following the hepatitis B and hepatitis C infection, schistosomiasis, leishmaniasis, malaria, and other chronic infection. Providing a causative relation between the renal disease and infection in individual cases is difficult. Next, we come to the acute post-infectious glomerulonephritis. Next, we come to the rapidly progressive glomerulonephritis. Next, we come to the acute post-infectious glomerulonephritis. As the name suggests, acute post-infectious glomerulonephritis, that is, after the infection at the acute stage, glomerulonephritis is coming. It is most common following the infection with certain strains of streptococcus. So after the streptococcal infection, post-infectious acute glomerulonephritis is occurring, and therefore it is often called as post-streptococcal nephritis. It is most common in children. The latency is about 10 days. So after 10 days of infection, the symptoms are usually appearance. There is throat infection and longer after the skin infection. It is rare in the developed world as compared to IgA nephropathy that is most commonly seen. It suggests an immune mechanism rather than direct infection. So there is immune mechanism rather than direct infection. The symptoms of acute post-infectious glomerulonephritis includes sodium retention, hypertension, and edema. So we have sodium retention, we have hypertension, and we have edema. There is reduced glomerular filtration rate. There is proteinuria, hematuria, and reduced urine volume. So the symptoms of acute post-infectious glomerulonephritis that is occurring due to the streptococcal infection. The symptoms include sodium retention, hypertension, and edema. There is reduction of the GFR, proteinuria, hematuria, and reduced urine volume. There is also urine. It has a red or smoky appearance. There is low serum concentrations of the C3 and C4. There is an evidence of streptococcal infection, that is ASO titer, culture and throat swab, and the other microbiological sampling. Management of the fluid and sodium restrictions and use of diuretic and hypotensive agents. The treatment consists of correction of the fluid and electrolyte imbalances. So there is management of the fluid and sodium restrictions and the use of diuretics and hypotensive agents. The treatment consists of correction of fluid and electrolyte imbalances, and it resolves spontaneously. Next, we come to the rapidly progressive glomerulonephritis. As the name suggests, it is progressing rapidly. It is an extreme inflammatory nephritis that causes rapid loss of renal functions. So as it is progressing rapidly, it is causing loss of renal functions over the days to weeks. A subacute reduction in the GFR greater than 50% with evidence of proliferative glomerulonephritis causes overlap with those of the acute glomerulonephritis. There are three major subtypes on the basis of renal biopsy findings and pathophysiology. Number one, we have immune complex that is associated, example in case of SLE. Second is posse-immune associated with anti-neutrophils, cytoplasmic antibodies. And the third variety is associated with anti-glomerular basement membrane antibodies that occurs in Goodpasture syndrome. So we have first immune complex associated that is seen in SLE. Second is posse-immune associated that is with ANCA. And the third with anti-glomerular basement membrane that is seen with Goodpasture syndrome. So let's discuss them one by one. So first one is the SLE, where there is renal involvement that is due to deposition of circulating immune complexes. There is non-renal syndrome symptoms of the SLE that includes arthralgias, that is joint pains. We have butterfly skin rashes, sclerositis, alopecia, that is hair loss, and central nervous system diseases. In the nephrotic syndrome with renal insufficiency that is common, renal biopsy reveals mesangial, focal, or diffuse glomerulonephritis and or membranous nephropathies. It is characterized by active sediments, severe proteinuria, and progressive renal insufficiencies. The treatment includes glucocorticoids and cytotoxic agents with oral or IV monthly cyclophosphamide for a period of 6 months. So in the SLE, there is renal involvement. It is due to deposition of circulating immune complexes. There is non-renal symptoms of SLE includes arthralgias, butterflies, skin rashes, sclerositis, alopecia, hair loss, and central nervous system disease. We also have renal biopsies that reveals mesangial, focal, or diffuse glomerulonephritis or membranous nephropathy. And it is characterized by active sediments with severe proteinuria, progressive renal insufficiency. The treatment includes glucocorticoid cytotoxic agents with oral and IV monthly cyclophosphamide for a period of 6 months. Next, we come to the second variety that is known as anti-neutrophil cytoplasmic antibody, that is ANCA, focal segmental necrotizing glomerulonephritis. So it is defining characteristic is present in presence of circulating ANCA. So in this variety, there is presence of ANCA. These are detected by immunofluorescence or alcohol fixed neutrophils. There is symptoms, prodromal flu-like syndrome. So there are prodromal flu-like symptoms which may encompass myalgias, fever, arthralgias, anorexia, and weight loss. The treatment of progressive glomerulonephritis includes methylprednisolone and cyclophosphamide with corticosteroids and cytotoxic agents. The segmental inflammation and or the necrosis in some glomeruli, and there is also small vessel vasculitis. Next, we come to the third variety, that is anti-glomerular basement membrane disease, that is also known as Wood-Pasture syndrome. It is caused by antibodies against alpha-3 NCI. So anti-glomerular basement membrane disease or the Wood-Pasture disease, it is caused by antibodies against alpha-3 NCI. The circulating anti-GBM antibody and linear immunofluorescence on the renal biopsy establishes the diagnosis. So diagnosis is established by circulating anti-GBM antibodies and linear immunofluorescence. There is Wood-Pasture syndrome that encompasses glomerulonephritis and lung hemorrhage. And the treatment is done with the glucocorticoids, cyclophosphamide, and plasma exchange to remove the circulating antibodies. So this is all about glomerulonephritis. Now it's your homework to go through the book and you have to complete this topic by completing your e-notes. I've also uploaded the e-notes and the PPT on the portal. So this was all for today. And this session is powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.